I'm Dr. Anant Malhotra, Additional Professor in the Department of Neurosurgery, SGPJMS, Lucknow. I will be talking about the anatomical considerations for OLIF. Now, before I talk about the anatomical considerations of OLIF proper, just a few words about the various approaches that we have for the interbody fusion. If you go dead posteriorly, we have the PLIF, as you can see here, and in the coronal section, as you can see here. And this is one of the techniques which, as spine surgeons, we are much more well conversed with. And if you go slightly more laterally, we have, or the posterior laterally, we have the TLIF. If you go that anteriorly, we have the ALIF approach, that is the anterior lumbar interbody fusion, as you can see here, and this is one of the best suited approaches for L5S1 level. Then you can go that laterally, that is the lateral lumbar interbody fusion or the XLIF. And then if you go anterior laterally, you have the OLIF approach, and this is also known as the ATP, that is the anterior to psoas approach. In the corner section, you can see here that you are going through the psoas muscle in LLF and you're going anterior to the psoas muscle as OLIF. Now, what is the primary difference between LLF and OLIF? LLF is a much more direct approach in which you could that laterally, and a better decompression of the disc space can be done, and so a larger cage can be used as far as the LLF is and OLIF is concerned. But the problem is that you have to go through the psoas muscle, and as we shall see in subsequent slides, the psoas muscle actually houses the lumbar plexus. So there's always a chance of injury to the lumbar plexus, and to avoid that, you have to use intraoperative neuromonitoring. To circumvent that risk, OLIF was developed, in which you have to go anterior to the psoas muscle and you have to take an oblique trajectory, and that is why this is known as the OLIF. Now, the structures that are important for OLIF are the first of all are the three muscles which form the anterior abdominal wall, that is the external, internal, and the external internal oblique and the transversus abdominis muscle. Then you have the psoas muscle, which you can see here is housing the lumbar plexus. Then you have the peritoneal cavity, the retroperitoneal space, along with the retroperitoneal structures, especially the ureter. The great vessels are there, and the sympathetic chain is there. So let us take that one by one. I'm not going into the details of where do you want to place the incision. That shall be taken up by the subsequent author, what position the patient should be in. Now, once you have placed the skin incision, then you have dissected off the subcutaneous fat, then you encounter the external oblique fascia, which needs to be sharply incised. Once you sharply incise external oblique fascia, then you have the three muscles, that is the external oblique, the internal oblique, and the transversus abdominis muscle. The important thing is that the dissection of these abdominal muscles is a blunt dissection, and you have to do the dissection along the direction of the fibers. Now, what is important here while we are doing the dissection of these three muscles is that sometimes that these three nerves, the subcostal nerve, the iliohypogastric nerve, and the ilioinguinal nerve might come in your way, especially between the internal oblique and the transversus abdominis muscle. When you're working between the internal oblique and the transversus abdominis muscle, you have to be very careful not to injure these vessels depending upon the level at which you're operating upon. You have to preserve these nerves, because if this injury to these nerves, then the chances are that patient might land up with a patch of hypoesthesia on the anterior or the lateral abdominal wall, which might be very discomforting for the patient. Now, once you enter into the abdominal cavity, you primarily firstly what you do is you try to hit the quadratus lumborum muscle, and then you slide your finger over the psoas muscle, and then you push on to the retroperitoneal content anteriorly, so that you can develop a space between the aorta and the psoas muscle here. So coming to the psoas muscle, which is perhaps one of the most important landmarks for the OLIF. So psoas muscle actually has two parts, the superficial part and the deep part. On the left side of the diagram, in this diagram, you can see on the right side, the psoas muscle is attached. The deeper part of the psoas muscle attaches to the transverse process of from L1 to L5 vertebra, and the superficial part attaches to the lateral surface of the vertebral body from T12 to L4. And between the superficial and the deep belly lies the lumbar plexus. And this is extremely important to understand because the psoas muscle forms the lateral boundary of the OLIF. Now here you can see, just continuing with the dissection of the psoas muscle, on the right side of this diagram, you can see the psoas muscle is there and the genitofemoral nerve is penetrating the superficial belly of um, the psoas muscle, and you can see here, but this usually comes quite later, so you are not much worried about the genitofemoral nerve because that is quite slightly away from your working area. But here, once the part of the psoas muscle has been removed, then you can see the lumbar plexus has been exposed. Now, if you look carefully, the nerves associated with the lumbar plexus are much more medially in the lower part of the lumbar vertebrae. That is why what happens is when you move more caudally, the lumbar plexus tends to becomes more superficial and tends to become more medially, and that is why operating at L5S1 level using the Olip technique is slightly more tricky, because the lumbar plexus might come in your way, might get injured if you are not very careful. So these are the other the two nerves that which are very important, neural structures which are very important in with relation to the psoas muscle. You also have the sympathetic chain, which is on the lateral border of the vertebral body. You have to be careful while placing the retractors or the tubular retractors not to injure the sympathetic chain. Now, coming to the great vessels, we all know that the aorta and the inferior vena cava. The aorta bifurcates into the iliac vessels at the lower border of the L4 level. You have to see it on the MRI whether it is bifurcating at a higher level or at a lower level, so that you can decide your trajectories, that what approach has to be used. Now, the once the aorta bifurcates into the iliac vessels, you can see the space between the psoas muscle and the aorta is significant out here. But here, as you move below, the gap between the iliac vessels and the psoas muscle is significantly reduced, and this is another reason why operating at L5S1 level using the Olip technique is slightly more tricky, because of the reduced space between the vessel and the psoas muscle. And apart from that, other reason why people usually avoid L5S1 OLIF is the presence of the iliac crest. However, people are doing a transiliac approach to L5S1 level for OLIF. That can be done, but there are other approaches which can be seen. Now, just moving on to the diagram on the right side, you can see here that we have the ureter. The ureter actually courses, initially it courses medially at L2, L3 level, and then it courses laterally, and then again comes medially to enter into the luteal bladder. But that this medial direction is, or medial course is quite at a lower level. It is at about S3, L4, S3, S4 level, in which we're not concerned with. So it is at the L2, L3 level in which the ureter is slightly more medially and more chances of injury can take place. We shall see in the subsequent slides. So the other vascular structures which are important are the renal arteries, L1, L2, and L2, L3 level, depending upon the right or the left kidney. But perhaps more important are the segmental lumbar arteries, which are direct branches of the aorta, and they course posterior laterally over the vertebral body. And so meticulous dissection of the vertebral body and over the disc space has to be done, so that these vessels are not injured. If these vessels are injured, then significant amount of blood loss can there, which might become very difficult to even to control. Now, another important vessel that might be encountered is the iliolumbar one, especially at the L5 level. So, how to prevent that? Many people actually advocate not to use the fixating screws at L5 level. That can be done, but if you have to use the fixating screws, then what needs to be done is you need to do a meticulous dissection over the vertebral body, see that none of the segmental artery or any of the veins is not there, so that the vascular injury, can be minimized or negated. Now, once you are doing the dissection, once you're pushing the retroperitoneal fat along with the contents anteriorly, so you will push the retroperitoneal fat along the contents. What happens is the ureter also moves along with the retroperitoneal fat anteriorly, and so you need not worry much about the chances of injury to the ureter. However, at the upper level, as I had mentioned earlier, at L2, L3 level, because the ureter is slightly more medially, one has to be more careful while doing the dissector, and also while placing the tubular retractors. Tubular retractor can injure two things. One is the ureter, and as I had mentioned earlier, the sympathetic chain. Once another thing that will come well that you encounter is the peritoneum. Usually, the peritoneal injury can occur during the dissection of the transverse abdominal muscles from the peritoneum. Even if there is an injury, you can simply suture it with the catgut or a Weichel suture. But try to avoid the injury. What you need to do is you have to dissect as laterally as possible. If you dissect as laterally as possible, then the chances are you will land up in the retroperitoneal space into the retroperitoneal fat. So the chances of injury to the peritoneal structures or peritoneal shall be significantly reduced. I'm not going to the details of the preoperative evaluation. The important things to look at the MRI is the aorta and the inferior vena cava. You need to see the distance between the aorta and the psoas muscle, so that you can see the distance. And distance should be at least a meter. Sorry, at least 1 centimeter, so that you can work between these two region. That is the aorta on one hand and the psoas muscle on the other hand. So this is all about the anatomy of the that is related to the olive, and in the subsequent lectures you will learn about the procedure, the indications, and the complications associated with them. So thank you very much for